Sorry, we had a serious network hitch over here. That's why I think we had this challenge. Okay. Professor, sorry for the time. Professor Eleje, are you with us now, sir?
Yes,
Okay, great. Yes, it's good to see your face. Well done, sir. And thank you for
thank you.
coming. And also thank your wife for the support services that she did, if she's hearing that.
Okay,
Thank you.
thank you.
So we would just like to know who Professor Eleje is, and share a bit of your background history with medical clinical trials.
Okay, I'm Professor George Eleje. I'm a professor of obstetrics and gynecology within NAFDAC University, Oka. I'm also a consultant, senior consultant within NAFDAC University Teaching Hospital, Newe. I'm a consultant obstetrician gynecologist. I'm a research coordinator with our effective care research unit, which is domiciled in our department. And I'm also the deputy director of research and innovation in our university, NAFDAC University. So most of my work is to conduct research, coordinate research, and clinical trials, and evidence-based medicine, systematic review and meta-analysis. This is what we do in the university and in the teaching hospital, and also capacity building. Thank you.
Thank you, sir. Now, what motivated you to choose the Mojeaga Herbal Remedy for this clinical trial on managing low blood levels in pregnant women?
Yeah, it is really interesting because we manage patients on a daily basis. And most of these patients do not, some of them say they don't need blood. And even though they may not be witnesses. So most time, and even those in the hospital, those who transfuse this blood transfusion, what of that, there are a lot of blood transfusion reactions. So it is also important to have an evidence-based product that can be an alternatives to these blood transfusion issues. So one thing again is before the trial, what we used to do, if we have some patient that have this blood transfusion due to religious faith, like Jehovah's Witnesses, we resort to the use of injection, both erythropoietin. These erythropoietin are injections given subcutaneously most of the time. And these erythropoietin are very expensive. Some patients may not afford it. So Mojeaga have offered another alternatives and cheaper alternatives to some of these drugs. An advantage it has is that Mojeaga can be administered orally. So these are the motivation. Because if we see an agent, an intervention, a drug that can offer the right alternatives, devoid of all those challenges encountered in those other things we used to give before, then it is a big motivation. So Mojeaga can safely be administered orally, and patients can take it even without the setting up the IV intravenous line, which sometimes may be difficult. And in the rural communities where there is no healthcare personnel, so patients can easily administer the Mojeaga easily without setting up IV line or requiring some special personnel like nurses or doctors to administer it. So because of these advantages, so many advantages, and I also looked at literature and found out that there has not been any publication on Mojeaga. So we decided that we have to conduct a clinical trial so that we can have a publication to rely on. I also observed that most doctors believe in science. Short almost all the doctors. If you are talking about drugs, they'll ask you, have they conducted any clinical trial on it? If you say no, then it means that they won't look at you. So for us to prove what we're saying or what the manufacturers are saying, it is very good to conduct a clinical trial. And that is why that motivated me to conduct this clinical trial, so that it will be at our bedrock, whatever we're saying. And it will be like from horse's mouth, that this is what we got from the trial we conducted. So these are all motives behind this.
Thank you. I think today we've gotten some very cool things, knowing the issue of administering some of these alternatives is very powerful, especially in indigenous as in rural areas. That's a beautiful part. You are really in the research, not just research for the books, research for what works. Because most people do research, but not really research for what works in different circumstances. Thank you so much, sir. Now, can you explain the methods, basic simply, because not everybody here might be a professional, of the clinical trial and how the participants were monitored during the process?
Please repeat your question, please.
Okay, the methods used in the clinical trial and how the participants were monitored during the process. In simple terms, we are not so much professionals here, all of us.
Yes, I know most people who may be listening to me may not be health professional. It's a mixed audience, actually. So, actually, if we want to do a study like this magnitude, we need to be scientific or not. We have to make it in a way that any person who is a reasonable person will understand it. And if we explain it to scientists, those who are monitoring who are taking these drugs, they'll be able to understand that we follow the rigorous process. So the methods we chose is what we call randomized. Because what we mean is that if a patient is coming to a hospital, we don't know, we try to avoid bias, what we call bias. What I would say, we don't look at faces. Because if you are doing a study and you see somebody who is your mother or your friend, and maybe you are comparing two drugs, because in this trial, we compared two drugs, what we were using before, and Mojeaga, in addition to what we were using before. So we try it in such a way that we avoid bias. Group, the next patient that will come will belong to. So that, because if you know where the patient will be recruited into, you may be influenced. Maybe if it's your sister or somebody, you now say, okay, since this one works better, you are going to be on this arm. You'll be given this drug, this is work better. But we made it in such a way that everything is by chance. It's by chance. It's not that we predicted what it should be. So you give everybody equal chance to enter the study. Some will receive the Mojeaga, some will not. And we follow them up. And end of the day, we'll now check those who received Mojeaga, because we looked at their blood level, their PCV, packed cell volume, before starting the study. Most of them have anemia. That is the indication for the study. Those who had anemia, pregnant women, and those who have delivered. But in this study, we try to avoid pregnant women in the first trimester, first 3 months. The reason is that since the drug is administered orally, so most of them at the first trimester usually have nausea and vomiting. So we don't want anything that they'll be taking that will worsen it, and it will affect the study. From second trimester, third trimester, we recruited them. And then we also involved those who have delivered maybe within 6 weeks and are having anemia. Those other ones were also involved. So they what to call, we didn't do actual blinding because it's an open label study, but randomization was done so that to avoid bias. So that was the method we used. So for issue of monitoring, yes, we involved NAFDAC. NAFDAC was involved from day one. We have to inform them, write the proposal, send it to them, and in Nigeria, we have to hire, and then we conducted it. But again, we have to defend the proposal. We didn't just go ahead and conduct the study. We had a series of both online meetings and physical meetings with them to defend what we want to do, because they have to be sure that the drug is both safe and effective, and that what we're giving to people will not harm them in the process of research. So that's why we are monitoring it. We also get ethical approval. We got it from different hospitals involved, because we involve 3 hospitals in the southeast. NAFDAC University Teaching Hospital, Nnewi, and then Chukwuemeka Odumegwu University Teaching Hospital, Oka, and also involve the Teaching Hospital, Parkland. So with all of them gave us their clinical ethical approval, in addition to the NAFDAC monitoring it. NAFDAC worked on it, looked at it critically, and we're giving them reports as we conducted the study. So I hope all the lay audience understand what I've said.
Yes, it's simple. It's simple. It's simple enough. Thank you. It is. Thank you, sir. So now, since it's a randomized study, okay, can you hear me now?
Yes, or face. Even if you are rich, or have to give the drugs free for every poor. I can hear you, so go ahead.
I think your explanation is simple, sir. The issue of randomized is clear, and the areas you ensure that you're able to get the feedback, who you actually used in this study, to avoid bias. Now, what were the key findings of your clinical trial, and how do they support the effectiveness of Mojeaga? If you could just give us maybe some of the data, the ones you can remember.
Okay, I want you permit me to share my slide.
Yes, we would love that, okay, sir, if possible.
Okay, let me check and share, because some of us will appreciate it more. Let me try and share this slide. More. Share. Okay, let me go to the findings. These are the results. From the findings, we study was conducted between, we started during COVID. COVID caught it. During COVID, the planning started before coronavirus. So, well, during the coronavirus it interspersed it. So between February 27, 2020, and first 267 participants, they were assessed for eligibility. Then after them, 72 participants were excluded for different reasons. Some of them, 58 of them did not meet inclusion criteria, because for you to conduct a study, they must meet inclusion criteria. Some of them have HIV/AIDS, so we removed, those ones were excluded. Those ones that have first trimester in pregnancy, as I said earlier, they were removed, and some declined to participate. So out of that 267, 95 eligible participants were now enrolled. We randomized them into the Mojeaga group and standard of care group. The other group received standard, I know what you normally do before, but 48 received Mojeaga. So in the baseline characteristics, there was no significant difference between the two at baseline. So the groups were balanced before starting the study. But after commencing the study, we looked at the median rise in the PAC7, what we call hematocrit. After because we looked at 2 weeks. The manufacturers also of the view that within 2 weeks, that was supposed to have effect if we administer the drug. And we now decided that we develop a protocol along that line to use 2 weeks at our time point for monitoring the outcome. So even though some people were questioning it, but that's what we decided to do in the study, because within 2 weeks, we were able to raise from the result. Within 2 weeks, for Mojeaga group, 10%, while in the standard of care is 6%. So it was significant. Now, we also looked at median hematocrit values at 2 weeks follow-up. The value itself, the other one is rise. Like, for instance, what I mean by rise is, assuming that the packed cell volume or hematocrit was 15%. If you add 10 to it, it will become 25 after giving the Mojeaga. But only for standard of care, only 6 rise in the hematocrit or in PC. But another name for hematocrit is packed cell volume, 6% rise. But in Mojeaga, within 2 weeks, there's 10% rise. You understand? So that was significant. As you can see, that p-value is less than 0.001. Anything less than 0.05 is significant. Now you look at the median hematocrit values at 2 weeks follow-up. It was also significantly higher. The rise in hematocrit, for the Mojeaga, those who were anemia before, but within 2 weeks, the mean was 31%, compared to 27.7% for those who did not receive Mojeaga. Then we also looked at the secondary endpoint, like tolerability and other clinical parameters. In terms of tolerability, there was no difference in the outcome. Now, we looked at, a patient who have anemia, they normally have dizziness and weakness. So we look at the improvement in the dizziness score and weakness after taking Mojeaga. We found out that there was a greater improvement in the dizziness score. Majority of people who received Mojeaga, their dizziness disappeared faster and weakness disappeared faster compared with those who did not receive Mojeaga. We looked at the adverse event, because if we're conducting a study, the side effect or adverse effect are very important, because these are areas people are also interested in. Because not only how efficacy, look at also the side effects. The adverse events were noted no adverse event was noted in either group. And there was no recorded maternal or fetal there, because, as we said, pregnant women were taking it. So during the course of the trial, fortunately, we did not receive any patient that had their baby died after receiving Mojeaga or the other group. That was an interesting finding. So that's showing that it is relatively safe based on the number of patients we recruited. We also looked at the proportion of participants with persistent anemic symptoms. I have mentioned this already. Let me go to other. There's also no case of treatment failure. Now, I've mentioned adverse event. We also looked at outcome particular to pregnancy. Know that some things that if a person is pregnant, they will be afraid of. For instance, if it takes Mojeaga, does it cause congenital anomaly or preterm labor, making the woman to go into labor faster before 9 months, or have rupture of membrane, or the weight of the baby? We looked at all those things. And both groups experienced comparable decrease in fetal adverse events. There was no recorded congenital anomaly. There was no incidence of preterm labor or low birth weight in either group. So all these things are safety measures. Now, we can get details if you see the paper manuscript published, which I know the details are also seen in this slide here, but some of us may not see it well because of the tiny nature of it. Now, what about the incidence of maternal adverse event like diarrhea, nausea, vomiting, colitis, and dropout due to the adverse event? Both groups experience comparable low number in maternal adverse events. Then, maternal adverse events were recorded in 6.25% of Mojeaga group, but in the control group is 10%, and the difference is not significant. We also looked at the other parameters like the level of the kidney, because if you're giving a person drugs are metabolized in the kidney. The kidneys are the one that metabolize. So I mean, you have to urinate it. So we looked at does that drug have effect on the kidney? These are things we looked. We looked at the kidneys and the liver. We found out that there was no effect. The only thing that was significantly lower was sodium bicarbonate in those that received Mojeaga compared to, but other electrolytes were similar. There was no change in the electrolytes. Now, we also looked at the liver issues. There was no changes in the liver enzymes from what we got. Median levels of liver function tests at 2 weeks after initial therapy. There was no significant changes in the liver function test parameter, including the AST, ALT, and AL. These are liver enzymes. So, because if the drug is affecting the liver, it will affect the liver enzyme fast. The same thing with the kidneys. So, showing that they are all safe when given at that level. So, these are our results we got. Thank you.
Thank you so much. This is evidence-based, not them say. Let me use that word. And this is really interesting. Now, this is the last question, sir. Now, what do you think these results can impact on the perception of Mojeaga, especially among healthcare professionals and distributors? And then what's your advice in recommending it as a health solution?
Yes, it will, Dr. They said earlier on, if this is a herbal product produced in Nigeria. So if we are discussing with, but it works, but we have to test the claim, which we have done at this phase 2 trial. So what the impact it had now is that for doctors, at least they know that the drug have passed a clinical trial stage. So they have some trust in it now, unlike before. So if we now, any place we go, even outside Nigeria, like this study we presented in France, that was in 2 years ago. And they asked questions and they were very excited about it. So because it becomes a undergo scientific trial, then people have trust in it because, and also look at the way we conducted the study. It was rigorous. We followed all the due process. We didn't do cut and join, no. It was monitored, both ethically and by the drug control group, that NAFDAC. So it have impact on the way people are now taking it. And I believe that more people are now taking the drugs. Even in our hospital, people are now prescribing it. And it's available in the pharmacies. But again, we're also hoping that we'll conduct a larger study. Because even though we have conducted this study in 3 centers, it should be good to do a phase 3 and phase 4, which NAFDAC have also advised us. So hopefully, sooner or later, we'll conduct a more full-fledged trial to more robust finding that can easily substantiate our claims and other findings we might be looking at. So what we recommend now is that it is safe, so to speak. So we need to, patients who are taking it, at least they know that the level of, apart from that, we have conducted the clinical trial. People are already using it even before they study, but the unfortunately that there was no publication on it or no clinical trial on it. So, but those who have been using it before never died. Instead, they survived. The only issue that it was not no clinical trial to back it until now. We now have a clinical trial to back it, and we have got the similar finding that nobody died. Nobody that took the drug throughout the trial. There were 95 people that took it. Both their child, both the woman and the mother and the child, unborn child, never died. And we have also followed the babies up, those who have received the drug till now. For the past 2 years now, we have not had any problem showing that after 2 years that these babies have developed problems. We have not had something like that because those babies are also followed up till now. So this is another thing we have done to increase the level of trust we have in our study we conducted.
Thank you so much, sir. This is really a rigorous study. It's a very rigorous one. We appreciate. Okay, this is our questions for you. Now it's to the audience. If you have a question, please type in the chat box. For Professor George Eleje, this is from the horse himself, the horse's mouth. So it's not like, okay, what is this saying? What is this saying? This is him now. So if you have your questions, please type. Would love to hear your questions. I saw one where to Cecilia Ceci. So you could type your questions now. Okay, I'm hearing Margaret Bombs. Margaret Bombs, you tell us where you are reaching us from. How long is someone supposed to take Mojeaga for anemia? That's the question, sir, on the chat from Margaret Bombs.
What's the question?
How long is someone supposed to take Mojeaga for anemia?
Okay. Well, as was said, the one can take it for 2 weeks, 2 to 4 weeks, or even more. In as far as the problem have not been addressed. But majority of time, once you take the drug for up to 2 weeks, usually there is an improvement from our trial. I also know that some people, immediately they took the drug, within 48 hours, they do recover. Some people have said that it's a magic drug, but you have to back it up with science, and that's what we have done. So one can take it for 2 weeks, 3 weeks, 4 weeks, or even a week, even 2 days. Within 2 days, within a day, once I've taken it. And I know some patients, this one happened last 3 weeks. A patient came to hospital. She's a pregnant woman. She was seen and was admitted, and she had a PCV, I think it's 21%. So they wanted to transfuse her. She refused. She's not even a witness. She refused. So they now approached me. I now interviewed the patient, because the patient is also my patient. So I asked her, which one? He did that. The doctors who saw you said they want to transfuse you, but you refuse. Do you want alternative? She said yes. Then I gave her a Mojeaga prescription, just trial. Within 3 days, she said that she's fine, that she wants to stop taking the drugs. And I warned her, please complete it, because I don't want you to come again and the doctors will now start saying you will be transfused again. Take it up to 2 weeks prescribed, so that you will be at par with those who collect your put the reserve. Because usually for a woman to develop anemia, it means that the reserve have been depleted. So usually if you are correcting anemia, the first thing is that if you are correcting it, you first of all go to the reserve first before you now build it. Just like if someone who drive car and you have that car is now under excess, that is a low fuel capacity. So for the time you go to filling station and you buy little amount of fuel, you first of all go and fill the reserve first before coming up in the scale. That's what actually happened in human body. So I told her complete the treatment I prescribed for 2 weeks. And today, patient was very happy. She didn't receive blood transfusion again, which doctors already prescribed for her. And many people are like that. So 2 weeks.
Okay, thank you, sir. Can you hear me? Network. Can you hear me? Is okay, we are back. Sorry, the network is acting up. Thank you for that answer, and it's really pointed, depending, and at least within a span of sometimes from 48 even to quite some time, so that they will be reserved. I like that part. The next question was from Lexi Lily from Port Harcourt. He said, during your slide, there was one element or something you said that was lower, that he wanted to get that clearly. That's what he asked in the question box. Then the other question was, apart from treating anemia, are there other things from your study that Mojeaga does? I don't know if you heard me, sir.
No, can you repeat the first question?
Okay, the first question was from Lexi Lily, and he said, during one of your slides, he couldn't get that exactly. There was one thing you said is lower. I don't know exactly what that is. And he wanted to get that clearly. On the slide before the last, okay, from Mr. Yoruba Berekadi. So he wanted to know exactly what that was. Was it just a general thing or what it is? But I know people here pay attention to details. That was a slide before the last one. That's one.
Okay. Yes, we found out that there was level of bicarbonate in terms of liver and serum electrolyte, urea and creatinine. Bicarbonate was lower. But the interesting thing about that bicarbonate that was lower than the one that in the people that didn't receive Mojeaga was that even though it was lower, the range was within the normal limit. Do you understand? The range was within the normal limit. Let me give an example now. Maybe let's use blood pressure as an example. Maybe we compared the blood pressure in people. The normal blood pressure may be, let's say, from 130, between, let's say, 90 to 130, all over. $70 to $80 or $60 to $80. Let's give an example. So those who received Mojeaga may still come within it was lower than those who did not receive it. But that lower limit is still normal for that individual. So I hope the person understands. So it's not that it is low, that it is abnormal. It's not abnormally low, so to speak. It was low, but it was a low normal. They were low, but it's still normal in the terms of parameter. So what may have caused it because, the way of administering the drug is in liquid form. That the liquid form is what we use. We also have a different form of the drug now, both in tea and other. So it's given in a form of syrup. So maybe the way it was administered might have contributed to that, or even it's a mixture of 3 drugs. So that may have contributed to the bicarbonate lower level, but it is still within normal level. It was not lower than a normal. I hope my explanation is clear to people who are asking the question. So even though it is lower, but the level we got was still within the normal limit. That was interesting finding. It was not like it's abnormally low.
Thank you, sir. I think it's clear. And I think that is why a database research is good. We would not turn numbers. We just show it the way it is. And we are happy that it's within.
Yes, we don't need to manipulate figures. No. We have to report that the clinical trial is blinded into analysis.
Thank you so much. So the last question I'm seeing in the chat, if there's a question I didn't see during the break, you can bring it back, is apart from anemia, from your study, are there other things you saw that Mojeaga Herbal Remedy can do for that particular range of persons?
Yes, the question is interesting. Actually, this is a clinical trial. A clinical trial is specific for a particular outcome. So we had a protocol which was designed to answer a particular question, and that is anemia. So we centered on anemia. In fact, we also looked at the adverse effect, which I emphasized in the result. So the study was purely on anemia. We didn't study other things because we need to be specific as possible. If I cannot in a study, just like some of us who do PhD or do masters, you have to write a proposal, and you have to be specific to that proposal. You don't deviate. So that's what we hope, that if we conduct further study, like phase 3 and phase 4 trial, we can now look at other indications for the drug. But we have seen also that it can improve immunity. It can improve immunity. So people who may have HIV may also benefit from the drug. it may improve immunity. So what we think, although we did not directly assess it. People have also talked about its effect on male fertility. I will not talk more about that because we didn't do a trial on it. It's only when we conduct a trial on it, we can talk about it. People will not misquote me. So it may have other indications. I know some people who are weak. They don't have anemia, but they're just weak. But if they take it, they gain energy. So you may have some metabolic activity. It may have it may have to play a role in increasing patients' metabolic rate. It might also help in solving insomnia. Depends. So only the study will, further trials will identify. You may have other important use, which the manufacturers are also claiming, but in our trial, we narrowed it to anemia and its adverse effects in those who have anemia.
Thank you so much, sir, for this. It's clear. And I think it answers some of the other questions I'm seeing about, apart from beta hematinics and other things, this answers it. It's interesting that we've had the time with Professor Eleje and with more than 30-something persons coming from different parts of the world and the country. And I think this is a beautiful thing. I must thank Professor Eleje. In a time where so many medical orthodox professionals are a bit biased about herbal medicine, seeing somebody that said, okay, no, I know I'm a professional, but I want to check what this thing does based on empirical evidence, it's something that we appreciate. And I think this is now no longer just orthodox, it's now complementary medicine. Let me use some good English here.
Exactly.
So, yes,
Yes.
yes, complementary medicine. And I think it's the way forward as far as the basics of life for now, before we reach the real hope we are looking out for would really come. So it's a beautiful thing we had our time with you. I am not seeing any more questions. I've seen the questions that were asked. Okay, I'm seeing one from Caleb. He said, considering the fact that malaria induces anemia, do you recommend taking Mojeaga concomitantly with antimalarials or treating malaria? Although I know you are very careful of what you say, but what do you have to say about that?
No. I would recommend the drug works in consonance with anti-malaria drugs. So if you have a malaria, treat malaria. If you have anemia due to malaria, then you now bring in Mojeaga. Or you have dizziness, you have weakness due to malaria, you bring in Mojeaga, it plays a role there. It's not used for anti-malaria, no. You still need to take your anti-malaria because we have not seen from the study so far, though we're not conducted a trial on its anti-malaria property. And I don't think the manufacturers are claiming that it has anti-malaria property. No, I don't think so. But if in future we find out that those who are taking Mojeaga do not normally come down with malaria, then we might be thinking that he may have some prophylaxis against malaria. This is another area we might study in future to check whether, if somebody is, those who are having malaria constantly, we might advise them to be taking it maybe every day for 1 month, particular quantity. And now we'll check whether they will develop malaria compared with when they didn't take it. If eventually the malaria stops in them, then you may start thinking that in that line that maybe it may have anti-malaria property. But before then, we won't claim or we won't say that it have anti-malaria. So we are still advised that people should take anti-malaria drug. But if they have other symptoms like anemia, dizziness, and the weakness, they can now bring in Mojeaga. That's what I would recommend, not for anti-malaria for now.
I think that's a very balanced answer. Thank you so much for that, sir. Yes, it's good to be balanced. Okay, now the last question is, can the publication be made available? location of the studies, the one in Paris, and
Yes, yes, it's made available. It's
and it's been
available.
published.
I will publish it in plus one, and the plus one is one of the highest journal in the world. You have high impact. If you read the first 10 journals in medicine, plus one is among the best 10 in the world. And we're sure to publish it there. Again, the article is available publicly online. Some of you who are in LinkedIn, I already posted it in LinkedIn, but I know the organizers of this workshop can also share the finding to them, those who request it. So it's available. I will share it on the for those, but those can Google, just Google it. You can also see it. Once you Google the clinical trial on Mojeaga for preventing anemia in pregnant women, you will see it online.
That's true. And it's even on our website. Once you go to the scientific research, you see it on the website. Website is www.mojeagahealth.com. Mojeaja. MOJ, joy, EAG for girl, A, health.com. So you can go there and you see the full publication. You can download it. And that's how I encourage people to go to the website. It's been a very great time. I think that is the last question for now. I am excited and happy to have this. Interestingly, it's recorded and we plan uploading this on our YouTube channel. And for those who want it, although it's kind of a big file, so it may not be something that will be easy to drop on WhatsApp in our communities, but we'll upload it on YouTube. You can go there and you can watch it because it's a groundbreaking research for herbal medicine, especially for the growth of complementary medicine in Nigeria. And one thing we love in Mojeaga is evidence, structure, and ensuring that what you're doing is based on data. So, and we also want not to keep our guests waiting. It's just 5 minutes to 9. We appreciate the fact that you've taken time to come and sit down with us and listen. I want to thank Professor Eleje. You had another meeting. You had to juggle this and come with the support of your dear wife and the family. We also want to thank everybody that's here because without you, there is no Mojeaga. If we only produce it and we're all drinking Mojeaga, we don't have persons who are saying this one is good. They tell the next person there would be no Mojeaga more. So we see everybody here as a family and we are gradually rounding off. I just want to tell you that generally we'll be rounding off our financial year December, the third week of December. And we also have some interesting, exciting announcements to give to our distributors too. But for this is a herbal webinar. This is not a business webinar. So we'll be rounding off now. I don't know, Professor Eleje, you have last words before we finally. Okay, I'm seeing 2 new messages. Okay. Yes, it's good. Okay. Mr. Michael dropped contact and yes, let's see. Thank you for your appreciation for the lovely information. Thank you for appreciating it. We will be rounding off now. Dr. Eleje, you have final words.
Okay. Thank you all for this scientific discussion on the clinical trial, randomized clinical trial we conducted on Mojeaga Herbal Remedy. It has been a nice discussion. We thank all of you for listening and keep updated and keep on researching. And then one day to continue to conduct more. We hope that by the time we conduct the phase 3 and phase 4 trials on this product, more indications might come up, and that will benefit our Nigerian population and African population and the world population in solving their problems, apart from anemia. Thank you.
Thank you so much, sir. And I was told that there are other big powers that be here. So I have to recognize them. Now, Professor Iasele he has also been a strong support behind the Mojeaga brand. We have persons who have loved us. Professor Eleje is somebody that loves the brand and took effort to do this research. And then we have Professor Iyasele. He came, even with his busy schedule. He has also been back end doing the serious research. He's in the chemistry department in University of Benin. We also have pharmacist Edo Sawe here. We have others. Please, I need to recognize you because we respect professionals. It takes a lot. We really do. Thank you so much for showing up. And this is how we would be ending this Mojeaga Health Webinar Series 13. We would have the next one in January. We're not going to miss that. The last Sunday of January, and it's going to be really packed full. So for now, this is how we end. We can see network even when we are ending it, maybe from the chat box and the rest. It's going to be interesting because we all grow with what we are doing now. So my name is Joy Eki Omovie, and I'm the host. Until next January, I'll see you again for the Mojeaga Health Webinar Series 14. Till then, thank you. Just Mojeaga it. Bye. Thank you, sir.
Bye-bye.
Okay.